ladies and gentlemen. It's a pleasure to be with you once again at the APICON 2022. I have just concluded my talk on pulmonary embolism. My name is Dr. Amrish Agrawal. I am a senior consultant in cardiology and a professor of medicine at a Fisher Hospital, United Arab Emirates. So pulmonary embolism is one of the most common, dangerous, potential lethal condition which is often ignored but commonly seen in clinical practice. Over these years, as our population is aging, the incidence and the prevalence of pulmonary embolism is rising, but fortunately, because of increased advances in medical care, the case fatality rate is going down over the time. So over these years, number of societies have come out with the guidelines on the paper, and because we in India, our population is geographically diverse, we tend to more follow the European point of the view. Typically, you will suspect pulmonary embolism in a patient who has got certain clinical features such as shortness of breath or tachycardia, but unfortunately, this symptomatology is common in patients without pulmonary embolism also. So the first step in a case of pulmonary embolism is the recognition of pulmonary embolism, and for this the European Society has put certain parameters. If somebody who is hemodynamically compromised and having a low blood pressure and there is not a possibility to shift for imaging, the first test of choice is doing a bedside echocardiography. Obviously, bedside echocardiography will give you a clue in the form of acute hemodynamic load on the right ventricle, which will be seen as the dilated right atrium, right ventricle, significant tracheal regurgitation, and particularly you can see the right ventricle is dilated at the base and the mid segments, and the apex of the right ventricle has preserved contractility, and we call this as the McConnell signs. If such a feature is there, then this helps us to establish the diagnosis of pulmonary embolism, or for that matter, if such a feature is absent in a hemodynamically compromised patient, this kind of makes the diagnosis of pulmonary embolism much less likely. However, the diagnostic capability or the diagnostic tool for the pulmonary embolism in the current scenario on 2022 remains CT pulmonary angiography because of its widespread availability, can be done in few seconds, and the widespread common reporting standards and the ease by the radiologist to report a luminal obstruction at the level of branch pulmonary arteries or the segmental pulmonary arteries. If you find such a pattern, you can really establish the diagnosis of pulmonary embolism. Once the diagnosis is established, it is important for a clinician to risk stratify the diagnosis, because on the one end of the spectrums are those people with a very low probability of hemodynamic compromise, and the other end of the spectrum are the people with the high risk of complications. Typically, if you have a low blood pressure, then and you have a patient hemodynamic compromise, it makes you very highly prone to develop complications of PE. Another parameters we use in our clinical practice is the PISA score and presence of biomarkers such as troponin and the BNP and the echo findings. If somebody is having high risk pulmonary embolism, which we defined before, such a patient should be subjected to reperfusion therapy. In the current era, reperfusion therapy indicates thrombolysis, means thrombolysis, and in some patients, if the thrombolysis is contraindicated and there are facilities available for mechanical reperfusion, we tend to use the patient with a catheter aspiration or catheter embolectomy or the ultrasound guided mediated embolectomy of the clot in the main and the branch pulmonary artery. And we at Fisher Hospital have a very good experience regarding reperfusion either by thrombolysis or by mechanical devices. So ladies and gentlemen, I come to the end of my summarization by saying that the three things in the case of pulmonary embolism. First of all is early recognition, second is risk stratification, and the third important thing is the treatment which rests on anticoagulation. And typically in the acute phase, we give them low molecular heparin, and in the chronic phase, this has to be characterized by novel anticoagulation. The guidelines are very specific that we have to consider extended therapy, which is typically consists after 6 months after treatment in most of the patients, unless somebody has got a major provoked pulmonary embolism such as recent surgery or a trauma. Otherwise, all other patients require consideration for our extended treatment with the half dose anticoagulation with rivaroxaban or redoxaban in the population or apixaban. So thank you very much, and we see you in some other APICON meeting down the line.